therapeutic efficacy, having some therapeutic efficacy will be developed in the future. If audience have any questions, they can type in the chat box and we can take it later. Now we move on to the bedside. So for the bedside, we have our senior resident from PGI Chandigarh, Dr. Yogesh, who is a third semester senior resident. He will be presenting an interesting case of lupus nephritis. So, Dr. Yogesh, can you please share your screen?
Share the PowerPoint page. Yeah.
Yes.
Full screen mode, Yogesh.
Good evening, sir. Am I audible?
Yes, you are audible.
Yes, you're audible.
Yes. Good evening to everyone. Today I'm presenting the case of today's session of ISN bedside case. My patient is RSK, 34-year-old female, a resident of a Jammu and Kashmir, housewife. She was diagnosed with the systemic lupus erythematosus in 2006. She was presented with the constitutional symptom mucocutaneous, hematological manifestation with renal and musculoskeletal. We will discuss this manifestation in further slides. She was presented in a current admission with a chief complaint of a dry cough since 8 days, hemoptysis since 3 days, and shortness of breath since 3 days. Coming to the background history, in October 2006, she was presented with a generalized edema associated with decreased urine output, and she also had a history of a fever with history of a frothy urine. She also had a painless oral ulcer involving the buccal mucosa and hard palate, shortness of breath on exertion, and inflammatory joint pain. She was evaluated outside and found to have a raised blood pressure and high creatinine level and referred to PGIMER for further management. She was evaluated in our PGI hospital, and we found out to have anemia and thrombocytopenia and creatinine around 4.5. On another other lab parameters, she had ANA 3 plus speckle pattern with low C3 C4 level, and dsDNA was positive. DCD was negative. Hemolytic workup was negative, and on urine routine microscopy, she had 2 plus protein and 3 plus blood. On 24-hour urine protein, it was around 2.8 gram per day. For the same, she underwent a renal biopsy, and renal biopsy was suggestive of a class 4 lupus nephritis. For that, she received a MPS pulse of 500 milligram 3 days, and she was after that has received the MMF induction and discharged with a creatinine of 2.4 with a urine output of more than 1500 ml per day. And she was continued on MMF maintenance, and MMF was stopped in 2017 by achieving the complete remission. In January 2020, she was again presented with anasarca and history of a frothy urine with shortness of breath. At that time, she found to have a 24-hour urine protein of 5.8 gram and creatinine of 0.7, and C3 C4 level was negative, low. It was a nephrotic flare, and she again underwent a second renal biopsy. It was again suggestive of a class 4 lupus nephritis. For the same, she received again a MPS pulse for 3 days and started again on MMF 500 BD, HCQ 200 milligram, and she was discharged. MMF was increased to 2 gram per day, and the steroid tapered off. Was lost to follow from 19th of February 2020 to August 20. And she again presented in January 2021 with a history of an anasarca with 24-hour urine protein of 3.6 gram with creatinine of 0.93, and patient was started on modified target therapy in the form of tacrolimus, MMF, and Visolon in view of suspecting the refractory lupus nephritis. Patient was again lost to follow-up since March 2021 to December 2024. In current admission, she was presented with a dry cough of since 8 days, hemoptysis since 3 days, and shortness of breath since 3 days. The dry cough was intermittent, non-productive, and there is no diurnal variation. Hemoptysis, it was abrupt onset, 3 to 4 episodes per day, around 20 to 30 ml of blood present in the bout, and it was since 3 days. And the shortness of breath also the sudden onset with gradual progression of MMRC grade 1 to grade 3, and it was aggravated by exertion, coughing and sneezing, and relieved by the rest. She again had associated symptoms of a facial puffiness, easy fatigability, reduced appetite, and decreased urine output. On the negative history, there is no history of a fever with cough, with expectoration, with the running nose. There is no history of a jaundice or vomiting. There is no history of a chest pain, intermittent palpitation, pedal edema. There is no history of any ocular or oral dryness. There is no history of a nasal, oral ulcer, skin rash, uveitis, sore throat, running nose, or ear discharge. There is no history of a oral ulcer or excessive hair loss. There is no history of a altered mental status and seizure. There is no history of any bleeding manifestation. There is no history of any addiction like smoking or tobacco chewing. There is no history of any drug exposure other than the MTT. And there is no history of any exposure to the rodent or rats or earliest discoloration of a sclera, urine, or myalgia. The family history was not contributory. On personality, she is a vegetarian with decreased sleep and the appetite was decreased. On menstrual history, she is P0, L0, A0 with irregular menses with oligohypomenorrhea, and the LMP was 22.6. On general examination, she had a high blood pressure level, that is 170 by 100 mm of Hg in right arm in supine position, with tachypnea around 26 per minute with a accessory muscle use was there, and the saturation was 93% at room air. JP was not raised. On A22 examination, she had a pallor, significant pallor with no icterus, cyanosis, clubbing, and lymphadenopathy, and no edema. On coming to the systemic examination, on respiratory examination, she had excess use of accessory muscles with on auscultation bilateral air entry with bronchial sound, and there is a bilateral diffuse fine script. No other significant finding on respiratory examination. On all other system like abdominal, cardiovascular system, and central nervous system, it was within a normal limit. Patient came to the emergency OPD at the PGI on 8th of December. She found to have a hemoglobin of 3.7 with a creatinine of 3.23 with a chief complaint of a dry cough, hemoptysis, and shortness of breath. For the same, she underwent the chest X-ray and HRCT, and it was says on X-ray she had a bilateral diffuse ground glass opacity, and on HRCT it was suggestive of a DAH. For that, for the anemia, severe anemia, she received the 2 PRBC transfusion, and for the azotemia, she underwent the dialysis. And after ruling out the infection, she received MPS pulse dose and plan to start on endoxon by NIH protocol. For the because of the DH part, she was started along with the above treatment. She started on daily plaques of 1.5 plasma volume removal with the kidney protective measures. From the above history, the patient likely had a diagnosis of a lupus nephritis flare or query refractory with diffuse alveolar hemorrhage. Thank you.
Thanks, Dr. Yogesh. A long clinical history starting from 2006. Okay, fine. So, of course, now you had an opportunity to go through the complete case records, and the diagnosis was very obvious that it was SLE, right? So,
Yes, sir.
But do you have, any kind of a differential diagnosis at the initial presentation?
No, sir. No, she does not have that much record of a 2006, but just 1 to 2 paper, and she had given the history of a just like inflammatory joint pain, oral ulcer, and the anasarca part at that time.
Okay, fine. So the multiple systems were involved, right?
Yes, sir.
Multiple. Cutaneous, you said cutaneous and mucocutaneous involvement was there.
Mucocutaneous, yes, sir.
And hematological was there, and renal was there, and arthritis she had, right?
Yes, sir. Inflammatory joint pain was there.
Okay. So quickly, let me ask you questions on this. So can you just describe what kind of arthritis in lupus you have?
Inflammatory arthritis, sir.
What do you mean by
Likely, the inflammatory arthritis involves mostly the small joint, bilateral,
Usually.
and usually symmetrical presentation was there, and
But
there is
it's
a
not mandatory.
more than 30 minutes, not
Yeah,
mandatory, and there is a more than 30 minutes of a morning stiffness is there, and mm, usually bilaterally presentation is there, and there is non-deforming and non-erosive. There
yeah.
is a typical for the
So what do you
SLE.
mean? Yeah, what do you mean by non-erosive arthritis?
Mm,
You know it. I mean, it does not consume the articular cartilage, right?
yes, sir.
Yeah. So that is the reason why it does not lead on to joint failure. So
Yes,
joint
sir.
failure meaning ankylosis and then permanent deformity. That does
Yes,
not
sir.
happen with lupus, whereas it happens very profusely and profoundly in rheumatoid arthritis.
Yes, sir.
Both are immune-mediated arthropathy. Both are inflammatory arthropathies mediated with an immunological background. But the clinical
Yes,
behavior is entirely different. This is very
yes,
important
sir.
because it is a non-erosive, meaning the articular cartilage is not affected at all. What you said is perfectly right. Usually it involves the small joints and it can be symmetrically, it can be bilateral and so on. But it can be of any type. Any number of instances we have come across just monoarticular of the knee and so on. But the common is what
Yes.
you said. But the common one is what you said, right? Okay, fine. And how commonly you come across the classical malar rash in your patients?
Malarash, around, sir, 60 to 70% of a patient.
Yeah, but
The
very,
malar.
very difficult. Particularly, it all depends on the complexion of the affected patient.
Yes, sir.
Yeah, only in very fair individuals it be there, and I mean, by and large, at least in our setup, we don't come across that much. So, what are
Yes,
other
sir.
skin manifestations? What are other skin manifestations in lupus?
In other manifestation, non-scarring alopecia, the typical hair loss of a lupus, like it is fragile, easily
More
pluckable.
importantly, which is classified under ARA criteria, classification criteria. Have you heard of discoid lupus?
Yes, sir. There are Gilliam classification was there for the cutaneous lupus.
Right.
They classify into acute, subacute, and chronic.
Okay.
In acute, we
Right.
got the typical like localized lupus rash and generalized lupus rash. In Localized, we had a but malar rash and butterfly rash, and in generalized, we got the all over the body same erythematous rash.
Fine.
It can present with a
what is
taint.
discoid lupus?
Sorry, sir.
What is discoid lupus?
Discoid lupus will come in the chronic lupus erythematous of a cutaneous manifestation, and in that it was presented with a scarring and scaling after resolving the
As the name implies,
skin
it's
rash.
a disc-like,
Yes, sir.
it's very circumscribed circular. The oid is like, it's a disc-like, so
Yes.
the name describes that one. Okay, fine. So how many criteria have to be there based on your American Rheumatology Association classification criteria to make a diagnosis?
Sir, currently we are following that entry criteria of ANA more than equal to 1:80 and more than equal to 10 points from the ACR ULR criteria.
Can you just elaborate on that?
Yes, sir. They are given the 2 points for fever, and in hematological involvement, they have given the leukopenia, thrombocytopenia, and autoimmune hemolytic anemia. It was 2 point, 4 and 4 point for the thrombocytopenia and autoimmune hemolytic anemia. Another for the serological, for arthritis, they have given the 6 point, and on serosities for the pericardial or pleural effusion, it was 5. It is 5, and for pericarditis, it is 6, and on cutaneous involvement, there is non-scarring alopecia, it is 2, and oral ulcer, it is 2, and for the subacute and discoid lupus, it is 3, and for
Okay, how many points?
acute cutaneous lupus erythematous, for it is 4, 4, I think.
Okay, let us not
And
dwell more onto this because we have to discuss so many things. Like,
yes, sir, yes, sir.
Please note down, and we can just revise that. And you are right. By and large, you are right. Okay.
And
So, when you suspect very strongly on the clinical background of lupus, how do you go about investigating?
I will evaluate the patient by first we get the probable idea from the clinical examination and the complaint of the patient, and we
Correct.
will
Investigate.
send the investigation like urine routine examination, 24
What
urine
what
routine
she had,
spot.
what she had. You can with your clinical case itself, you can discuss that. What was the urine finding?
Yes, sir. In our patient, she had a 2+ protein and 3+ blood, sir. On 24-hour protein, she had a 2.6 gram of a protein urea.
Fine, but 3+ blood is a dipstick. So how about
Yes, sir.
urine sediment analysis?
On sediment, sir, she had a 10 to 15 of RBC per high power field.
Yeah. So what is the
Yes.
importance of urine sediment? What is the importance of urine sediment in lupus?
It will give the idea of is it involvement of a glomerulonephritis or just nephrotic syndrome on urine. If it is active, like class 3, class 4 lupus nephritis, we will get the active sediment. And if it is like lupus porocytopathy or class 5, we will get only the protein, sir.
Okay, fine. So why I'm asking this question is that, the urine sediment, it used to be described as the liquid kidney biopsy.
Yes, sir.
In clinical nephrology, so much of importance given for that, and unfortunately gradually we are losing interest in that, and that should not happen. So somebody has rightly pointed out it used to be described as telescoped urine sediment. There is a classical description of telescoped. Yeah. Why do you call it as a telescoped urine sediment in lupus?
Like we will get all the findings like protein,
So
blood, WBC, and
yes,
WBC class stop.
exactly.
That intrarenal, it will suggest the intrarenal inflammation without infection.
No. With the telescope, if you look into the sky, what do you see? so many things you see, like,
Yes, sir. Yes.
the moon on the one side, moon, and then varying, the stars are varying size and varying glitter, varying color, and so on. So there is variegated appearance that you can get in lupus urine sediment. What does it mean? You can have, as you rightly said, plenty of RBCs, and RBC cast, if it is there, it is a proliferative lupus, is a class 4 and 3. On the other hand, if you get a coarse granular cast and then broad cast, at least some of the glomeruli have gone in for glomerular sclerosis with tubular atrophy of the corresponding tubules. So like that, you can have the whole lot of it, because we know SLE is not a one-shot disease like your anti-GBM antibody. It is just one shot. But here it is an ongoing waves of injury with exacerbations, flares, and then remissions, and so on. So that will be reflected on this. And the counterpart in the kidney biopsy is the same. If you have all these elements in urine sediment, you can see some of the glomeruli showing very significant proliferative glomerulonephritis in few, and then sclerosed glomeruli in some, and so on. That's it. So there used to be a lot of importance attached to the urine sediment. Many clinical decisions were taken based on urine sediment. That was the past. Even though we have to remember the importance, the vitality of the urine sediment, we cannot just take decisions based on urine sediment alone. Why? Because in a very pleasant lupus also, you can have some RBCs, if there is a local cystitis and a stone or menstruation and so on, all that you have to remember. On the other hand, if I remember right, at least 5% in some series, there is something called silent lupus. Your urine sediment may look very innocuous, but there can be a very significant lupus nephritis to the tune of even class 3 and 4. So the urine sediment is very important. Without that, you cannot proceed with further investigations. That is very important. But at the same time, you should know the limitations of the urine sediment as well. Okay, fine. So how do you ascertain that the RBCs in the urine sediment, which you see, are of glomerular origin?
If it is glomerular hematuria, we had rule of a 45 and 1, like 40% of a dysformic RBC, 5% of a acanthocytes, and 1 RBC cast. It is suggestive of a glomerular.
Good, very good.
Yes, sir.
Okay, then we have to move on to the CBC. So the components, as you have already said, anemia. What are the causes
Yes.
for anemia and lupus?
Most common are anemia of chronic disease. It can be because of nutritional deficiency, iron deficiency, vitamin B12 or folate. It can be because of the antibodies, autoimmune antibodies against the erythrocytes.
For that only you have done DCT, you have done that, right? Coombs
Yes,
positive.
sir. Yes, sir.
Model. So it can be hemolysis, or it can be anemia of chronic disease, or it can be a chronic duration of the disease. It can be due to the inflammation component of it, and then because of steroids and other things, there can be
Yes,
blood loss as well.
Yes,
So
sir.
anemia, it forms a very important component. And here in this particular patient, diffuse alveolar hemorrhage, there's so much of blood over there. Probably that's another reason.
Yes, sir.
In this situation, right? Okay. Anemia. Why there is thrombocytopenia in lupus?
There is a antibodies against the autoantibody against the first platelets, and
Okay,
it
fine.
can be because of the
Right. Okay, that's fine.
I-
And please remember, thrombocytopenia goes very well with the activity of the disease. It's an important assessment of the activity of the disease is clinical parameters, and then the investigation parameters, particularly the hematological, and then immunological parameters, and then of course histological parameters. The very commonly asked question in a long case, if it happens way, long case kind of, how do you assess the activity of lupus? You have to classify this way. On the clinical, the hematological and other lab parameters, and then immunological, serological, and then histopathology. Okay.
Yes.
And you mentioned about hypocomplementemia.
Yes, sir.
So what is the inference when you come across a low C3 as well as low C4?
If it is both low, there is a high chances of a patient presented with the lupus nephritic flare, or it can be happen in the class 3, class 4 lupus nephritis.
Class C4 is low means which pathway is involved?
C4 classical pathway, and if it is C3
So,
and alternate
meaning
pathway, sir.
you can't differentiate whether classical pathway or alternate pathway, both in
Yes,
both.
yes,
But
sir.
here, 4 is low. So, which other disease which affects the kidney presents as RPRF, you come across hypocomplementemia C4?
Cryoglobulinemia, sir.
Very good.
And
Very
yes,
good. Yes.
yes. And another we can get in subacute bacterial endocarditis. We can get
Okay. Where the classical
both
pathway activation?
PSG and
No,
PSG and
PGN alternate pathway predominantly. Classical pathway role is very less. Okay. Fine. Let us move on. Okay. So ANA was positive and anti-DS DNA was positive.
yes, sir.
Okay. Fine. So which is more sensitive?
Sir, ANA is more sensitive than
So, which is more specific?
specific anti-DNA, sir.
Anti-DS DNA. So roughly in what proportion of the patients with SLE there will be positivity of anti-DS DNA?
Around, sir, 60 to 70% we get the positive anti-DS DNA.
Little less than that. Most of the series only 40 to 50%. So, okay, how do you look for the presence of anti-DS DNA?
Sir, we by the critidase, you say that immunofluorescence by immunofluorescence or by ELISA, sir?
Fine. Which is more sensitive, which is more specific to detect the presence of anti-DS DNA? Enzyme immunoassay is
Yes, sir.
more sensitive.
More
Enzyme
sensitive.
immunoassay is more sensitive, whereas the immunofluorescence by using criteria luciliae, that is more specific. That is more specific.
Yes,
What is
sir.
this criteria luciliae? What is that?
It is
Trypanosoid, you know, that trypanosoid.
trypanosoid.
It's a double stranded circumscribed nucleus is there. So criteria luciliae, even now it is adopted in certain centers. And please remember the anti-DS DNA, there's wide variations in the positivity by the techniques with which you do. There are a couple of other techniques as well. So when the clinical evidence is there and hypocomplementemia is there and your pathology is pathology, just because anti-DS DNA is negative, it doesn't mean anything. So you need to repeat it and try to with a more sensitive methodology rather than sticking onto this immunofluorescence methodology using criteria luciliae. Okay, that's more specific if it is there. What is the importance of anti-DS DNA titers? Why we discuss so much about it?
Sir, anti-DS DNA titer, it is more specific in lupus, and it is suggests the disease activity in lupus.
Yeah,
it will suggest, and it will give the idea if it is positive, lupus more prone for the nephritis and vasculitis also, sir. If it is titer is on the higher side.
exactly. Okay, fine. Good. Then you went for kidney biopsy. You said it was she had. What was the age of the patient when initial presentation in 2006?
Around, sir, 16 to 17 year of age.
17 years. That time she was
Yes.
not married, right? That time she was not
Yes,
married.
yes, sir. Yes, sir.
Okay, fine. So the biopsy revealed class 3, class 4 lupus nephritis, according
Class
to you.
4 nephritis, yes, sir.
Class 4 lupus nephritis. So can you quickly, in a couple of minutes, describe what is class 4 lupus nephritis in kidney biopsy?
Class 4, diffuse glomerular involvement, sir. In that, it is more than it is segmental or global. That was previously we are using, but now we are not using in this class 4, and we can divide the patient on the basis of a activity and chronicity index.
My question is that the phenomena of class 4 lupus nephritis. What do you see in the microscopy?
Wire loop lesion, sir. In that
Okay.
we get the wire loop lesion, that subendothelial deposit with in continuous linear pattern.
The most important thing is it's a proliferative glomerulus. You know it is. You get sure. It's not that you don't know, but it was just for the repetition only I just asked. Basically, it's a proliferative glomerulonephritis. What do you mean by proliferation here? It is basically endocapillary proliferation. Endocapillary proliferation. Number one, you can also have mesangial proliferation. Also, you can have infiltrating neutrophils. And then you can have proliferation of the parietal epithelial cells that results in cellular crescent. So it's a kind of a very an intense proliferation. So class 3 and 4, basically a proliferative glomerulonephritis. By using proliferative glomerulonephritis, you mean actually endocapillary proliferation. Because the mesangial proliferative glomerulonephritis, that is a class 2, that there are also proliferation, but there is no capillary proliferation, right?
Yes.
So here it is endocapillary proliferation. Okay, and nephritis is one pathology where you can have infiltrating polymorphs and leukocytes as well, neutrophils as well. Okay.
Yes, sir.
Presence of neutrophils can be there here. Okay, that is there. And then you have cellular crescent. Cellular crescent is an important indicator of very active. So this is activity. Then you mentioned about the wire loop lesion. Anything else?
On EM finding, we can get one
light
specific
microscopy. No, light microscopy, the
full,
other phenomena.
sir, on light microscopy.
Pyrexis, fibrinoid necrosis.
Yes, sir.
Hyaline
Fibrinoid
thrombi.
necrosis. Yes, sir. Hyaline thrombi.
Hyaline
We can
thrombi.
get the. Yes, sir.
Hematoxylin body. Hematoxylin.
Yes, sir.
Okay. Of all these, which is supposed to be so unique for lupus, because the proliferative glomerulonephritis you can get in so many other diseases, right? Even MPGN and certain other C3 glomerulonephritis also you can rarely get endocapillary proliferation, IRG, and you get IRG, you can get endocapillary proliferation and so on. And wire loop lesion, even though you come across very rarely, there is yet another disease where you can get wire loop lesion is HIV. HIV. So cellular crescent get in so many other diseases. Okay, and fibrinoid necrosis also you can have. The necrotizing glomerulitis you can get in onca disease. So nothing is very specific for lupus. If at all you want to say something is little unique, little more specific for lupus, it is hematoxylin body.
Hematoxylin bodies by gross. Of gross.
Okay, so that you have to remember. And you need to know what is hematoxylin body, what is karyorhexis, and wire loop lesion already have said. These are all based on these, you determine the activity of the pathology. In fact, you are supposed to score. There are six important criteria for activity scoring, including interstitial inflammation.
Yes, sir.
Interstitial inflammation. So the 5 things are in the glomerulus. 1 is in the interstitial, right?
Interstitial. Yes, sir.
So this is activity index. Suppose at presentation, the kidney biopsy has got a very high activity index. What are the implications?
It will suggest we can give the immunosuppression therapy to that patient.
You are supposed to. Anyhow, you have to give. Yeah, therapy has to be uncompromised, appropriate, aggressive therapy has to be there. Sir. Beyond that, the current literature says that the initial high activity score, the chances for relapses little on the higher side compared to another patient where the initial activity score is not that high.
Low. Yes.
Particularly, the very important crucial decision every nephrologist will be kind of really flabbergasted or fumbling is when to stop immunosuppression, right? Particularly at one point of time, you take a decision to stop immunosuppression based on the complete remission and sustenance of remission and so on. In a person who have had very high activity initially, after withdrawal of immunosuppression, the chances for relapse little higher compared to. These are all needs and decisions. So it is not just a routine kind of an exercise to score and all that. Everything has got implications. And of course, there is a methodology of assessing the chronicity index as well. That is based on your glomerular sclerosis, interstitial fibrosis, tubular atrophy, and fibrous. So these are the 4 important criteria. Okay. What is SLEDAI?
The systemic lupus erythematosus disease activity index, in that around 24 points are there, and it is score of around 105. If it is 0 to 3, it is mild. 4 to 11, it is moderate, and more than 12, it is like severe disease activity.
Okay, fine.
Yes.
Fine. Good. The SLE disease, I've been learning for more than 3 decades. The understanding of the disease and the approach to SLE used to be entirely different in the past. The very favorite and very common question that we all faced as MD internal medicine students, subsequently DMS, early cell phenomenon. Now we know, no, we don't rely on early cell phenomenon to make a diagnosis of SLE, but still, it is a point of historical interest. Even recently, there was a publication from one of our colleagues from Tiruchirappalli SPSS Subramanian, beautifully has published early cell phenomenon in one of the journals. So just be prepared for that. There can be a surprise question even though it has lost its relevance in the current realm of lupus management. Can you just tell me what is your understanding of early cell phenomenon? Early cell.
I'm not
Yeah,
aware of.
simply. Early
Yes,
cell is nothing but a neutrophil. It's just a neutrophil. This neutrophil is trying to engulf the nucleus that is being attacked by the antibodies, anti-nuclear antibodies, and the denaturing and the destruction of the nucleus is happening, and the antibody is attacking, and this complex of the victim and the attacker is engulfed by neutrophil. Okay, that's it. So that used to be a nice title. I mean, on description article title. Is it the crime scene or the closing of the crime by the supervisor? That kind of thing. So that's the initial phenomenon. Fine. Anyhow, it's a thing of historical interest nowadays. We don't talk about it just for completion sake. I said that. Fine. You said about other systems. So why do you think she has developed a diffuse alveolar hemorrhage now? What is the pathology over there? Is it anything beyond SLE, or you are pretty sure that it is only lupus itself?
Sir, in this case, it is likely SLE related, like that is a pulmonary capillaritis
Very good, very good. The
form.
vasculitis. Yeah, it's a
Yes,
vasculitis, capillaritis. So it's a
yes,
kind of
sir.
vasculitis component. That is lupus vasculitis. There are some unfortunate patients with lupus where the vasculitic element is pretty high. They can have all this. They go in for very rapid worsening of the kidney function, and they present with diffuse alveolar hemorrhage and so on. So why I'm asking is that, in a patient with lupus and who has been on immunosuppression on and off with very potent drugs, very powerful drugs and so on, hemoptysis, pneumonia component, of course, I mean, there is a very strong clinical background to think in terms of lupus, but always keep a broader approach. There can be any
Yes,
like pneumonia, another
yes, sir.
bug might be invading
Yes,
the
sir.
and so on. Okay. So have you heard of vanishing lung syndrome?
Yes, sir. Like
It is not nephrology, but it's one of the manifestations of involvement of the lung in lupus. Actually, the
yes, sir. Yes, sir.
reduction in the lung volume.
It was associated with anti-row presentation,
Actually, you can have
shrinking less. Yes, sir.
the common pleuropulmonary manifestations are one is a pleural effusion, and of
Yes,
course then interstitial pneumonitis, and then
yes,
fibrosing alveoli interstitial pneumonitis. That is a very common one. And then a rare subset of them going for a progressive reduction in the lung volume. So a dry cough and a progressive breathlessness in a patient is this thing. Okay, and then of course on the capillaritis and lupus vasculitis presenting as alveolar hemorrhage. Fine. So if how do you treat lupus nephritis, class 4 lupus nephritis in a 16-year-old girl as your patient?
sir. Patient presented with like a 16-year-old female with a class 4. We have first we have to start her on MPS pulse, the 0.25 to 500 milligram for 3 days, and followed by 0.35 to 1 milligram per kg per day of a oral prednisolone. And coming to the immunosuppressive therapy, in that we have three option, like by endoxon by NIH protocol and Eurolupus protocol, and another is MMF. Uh, uh, she's a 16-year-old female and unlikely, like unmarried. So we can prefer the MMF in this patient of a fertility, which is a like law higher chances of a loss in by giving the endoxon. And for that MMF, we can give the 2 to 3 gram per day initially in the induction phase, and
So you prefer cyclophosphamide or
we
MMF?
prefer MMF in this case, sir.
Okay. What is the evidence that MMF is at least non-inferior to cyclophosphamide?
Sir, by when the study was done in 2000 at China, Hong Kong, at that state, it was like there is no difference between the by MMF plus predni and the cyclo plus predni. But there are some adverse effect of a cyclophosphamide regarding the fertility and that gonadal failure, a primary ovarian failure part.
Okay. See, so there are so many trials, so many important landmark studies in the management of lupus nephritis. What I would suggest is that you just broadly classify into the trials related to the two major things like cyclophosphamide, MMF. And of course, there is one study comparing MMF versus azathioprine as a maintenance. So these trials again subclassified as to the trials which gave some kind of insight regarding induction of immunosuppression regimen, and the trials which answered our queries on maintenance of remission. Okay, induction of remission and maintenance of remission. So that way it can be classified the important trials. Number one, that includes NIH, Eurolupus, ARMS, Aspriva, lupus maintenance, and there are so many trials you have to classify.
Yes,
The
yes.
second set of trials, the trials are the important trials with the currently, there are some drugs which become currently popular, right? Like what are they?
Like
Belimumab
belimumab, sir.
and oclosporin.
Voclosporin, sir.
Oclosporin. Okay. So the recent trials, and more importantly, something has come up in NEJM. What is that? In refractory lupus, you give something.
In that like CAR-T, CD19 CAR-T therapy, sir.
Please read that as well. So I earnestly appeal to all of you, just enlist the names of the trials in one page, number one. That is the first step. You classify them. The previous decades trials and the current trials. Okay. And then you classify them as induction immunosuppression and maintenance. I would like to know from you the landmark trial published from PGI Chandigarh.
So the published in 2000, yes, sir.
Manish Rathi and
in
team.
2016, there is no other than this trial. There is a comparison between the low dose cyclophosphamide with MMF, sir.
Please go through that. And
Sir, in that, sir,
it was published in which journal? Kidney International. I would request all the attendees to go through that, not just the original article and the beautiful editorial commentary written on that. Like why it was considered important is that the so-called the Eurolupus regimen, the fixed small dose cyclophosphamide.
Yes, sir.
In that Eurolupus, as the name implies, all the the study subjects participants were only Caucasian. Okay, whether that can be extrapolated to non-Caucasian population. So this is a randomized control trial. That's why it assumed so much of importance. Please go through the original article as well as the editorial commentary, beautifully written. How the concept flew from the Western world to the Eastern world. So that way, okay. So what is this
Yes, sir.
Euro-Lupus regimen? What is this Euro-Lupus regimen?
In Euro-Lupus regimen, we give the fixed dose, 500 milligram of a cyclophosphamide every 2 weekly. It will for 6 dose, and after that, patient we will shift on the maintenance phase. Sir.
Okay. So then subsequently, it was compared with, and it was compared with mycophenolate mofetil also.
Yes, sir.
So one is the low dose, and then comparison with mycophenolate mofetil. Okay. So
Yes, sir.
comparable results. So this is one important concept that you have to remember. There are 10 common mistakes nephrologists do in the management of lupus nephritis. Have you read that article published a few years ago in EduKD? One of the important, in fact, this is the first mistake the author highlights. Assuming that cyclophosphamide is the gold standard agent in lupus nephritis. So, particularly when you handle class 3 and class 4 lupus nephritis, thinking that if you don't give cyclophosphamide, you are doing injustice to the kind of patient. So that used to be kind of a long-held belief. So there is one common miss because the trials, including an Indian study, has proved that MMF is non-inferior. So that is an important. What are the problems with cyclophosphamide apart from the theoretical possibility of gonadal toxicity?
There is a problem of a GI intolerance and myelosuppressions. It can have a side effect of a
side effects, infectious complications. Okay, and suppose if you give, and what about hemorrhagic cystitis in some people? Yeah.
Yes, sir.
Fortunately, it is not that common, but still, please remember hemorrhagic cystitis. So to prevent that, what do you do?
Hydration. No, currently, we are following just hydration. There is no role of a MACE. Like one study was done. It was not
that's
certain.
the
Yes, sir.
so initially,
Yes,
Mesna was very much
yes,
and
sir.
most
Yes,
centers
sir.
don't use. So necessarily, you have to give it in the morning so that you can ask the patient to consume a lot of water. If there is no edema, if there is no oliguria, so that frequent voiding, so that you minimize the duration of contact of acrolein. That is the injurious component of the cyclophosphamide. That in contact with bladder mucosa, that causes that one. We give cyclophosphamide in the morning. Late in the evening, patient becomes disoriented. What do you think could be the cause? Can it cause, can release some hormone and bring in some electrolyte abnormality? Yeah, SAAD, right? It can stimulate ADH release, and that can cause hyperlipidemia. Fortunately, this is a little less only. Can SLE per se can cause SAAD? Rarely.
Rare. Yes.
So dyselectrolytemia in SLE. Dyselectrolytemia in SLE, that is hyponatremia due to the disease per se, and then cyclophosphamide can cause.
Yes.
How do you explain hypokalemia in SLE? Dr. Niranjan is answering so many things. Yeah, good. Fine. It is a renal tubular acidosis, the tubular dysfunction. So why I'm asking this question is that, when we say lupus nephritis, we are focusing only on the glomerular compartment, In fact, that is one of the flip side of the renal pathology society classification, ISN RPS classification. It does not address the involvement of the kidney in its entirety due to lupus, because it is confined only to the glomerular pathologies. Okay, so what are the let us finish the management and then we'll go on to the other things. Have you heard of Aspreva lupus maintenance trial? And if you know, you can quickly rattle off. Otherwise, others can just note it down and then go back and do. I think.
Sir,
The primary purpose, let me finish. The primary purpose of the trial may be different, and there are that or Aspreva lupus maintenance. This study gave an important clinical insight. It showed that the hydroxychloroquine that has a positive impact in terms of reducing flares, the rate of flares. Okay, so such observations made it mandatory that HCQS classes is to be. This is the second one of the 10 common mistakes. First one I said, it's thinking cyclophosphamide is the gold standard. Another common mistake is that frequently forgetting this hydroxychloroquine, forgetting about it. So why do you give it, and how do you give it? What are the maximum dose? How do you monitor a patient on HCQS?
Sir, the usual dose is 5 milligram per kg per day. The maximum, not more than that. And
Maximum dose
before,
is 5 milligram. Yeah.
yes, sir.
Good.
Before starting that, we can do the test of a G6PD in considering in male and some Asian and African population. And after starting the HCQ, we have to continue that HCQ in the like in pregnancy or after stopping the immunosuppression in future also. And for the monitoring purpose, first, if, there is no need of a ophthalmologic evaluation before starting, but after starting the HCQ, after 5 years, we can do the evaluation of a eye,
Ideally, at
and
least once a year. Ideally, at least once a year.
and after
What do you?
that, it is once a year. After
Now, what
that,
is
it is
what is the problem you anticipate?
the involvement of a
Bullseye
macular involvement of maculopathy, bullseye,
Bullseye maculopathy. Okay?
maculopathy. Yes, sir.
So it is an immunomodulant. Now there are very good articles have come up as to what is the role of hydroxychloroquine. Very well tolerated, very well tolerated. And another important point is that it need not be stopped during pregnancy.
Yes, sir.
It need not be stopped. It has to be continued during pregnancy. That's it. Okay. The other problem is that with the cyclophosphamide is that, the gonadal toxicity. Suppose if you feel that you have to resort to cyclophosphamide only to some other reason, mycoplenate is not tolerated by the patient or some other contraindication for that, and patient is unmarried, and you are worried about the gonadal toxicity. What do you do?
So the preservation method for the OA and the sponsor to get the
Good. Then one more thing. Can you give some agent?
GnRH agonist leuploride. We can
Leuprolide.
give.
Yeah.
Yes, sir.
Yeah, leuprolide can be given. Okay. And again, remember that, the small dose, 500 milligrams, maximum 6 doses and so on, by and large, it will not inflict that much of the gonadal toxicity, but these are the points that you have to remember. Okay, fine. Then, so how do you, what are the chances for maintenance therapy once you achieve induction of remission?
Sir, around 10 to 40% patient achieve the complete remission,
How do
and
you
there
define?
is
How do you define a complete renal response?
as per the
Oh,
latest
and
KDIGO guideline.
and just one second. I mean, I hope all of you have gone through the 2024 KDIGO guidelines on management of lupus nephritis, right? If not, please go through that. So beautiful. The summary of the whole lot of it, updated. So based on that,
As per the current KDIGO guideline 2024, the complete remission said there is a 24-hour UPCR less than 0.5 gram per gram or less than 50 gram per millimole. And there is a stable or improvement in the kidney function 10 to 15% plus minus baseline. And This may be in 6 to 12 months, or it could be more than 12 months in some patient.
Okay. Fine. So you are perfectly right. So what is partial response?
Partial response in that there is a more than 50% decrease of a proteinuria, or less than 3 gram per gram of a 24-hour UPCR, and the same other 2 points, stable or stabilize or the improvement of a kidney function around 10 to 15% of a baseline, and it is also in 6 to 12 months of a therapy, or it could be more than 12 months in some patient.
Okay. In this 2024 KDIGO guidelines, any modification as compared to previous guidelines in the management of classical lupus nephritis? Because you said either the choice is either apart from steroids, you have two choices. One is cyclophosphamide, that is a 500 milligram low dose, and then or mecophenol or mecophenolic acid. That is the previous guideline.
We can
Other options?
in other option, like we can give the CNI by giving like the triple immunosuppression therapy along with MMF and predni in that patient. In that we can prefer the voclosporin
One more. Yeah, this is one
and
more.
belimumab, sir. Rather
Belimumab.
belimumab.
Yeah,
Yes, sir.
yeah, this is the modifications. No, I'm not saying that we have to go for belimumab. This is a modification because we are supposed to know because of the KDIGO guideline. Please remember these points. Another important point in the current KDIGO guideline is that in a patient with proliferative classical lupus nephritis, what should be the minimum duration of total therapy? Minimum duration of total therapy, meaning induction of remission plus maintenance of remission.
At least, sir, more than equal to 36 months they have mentioned, and
Exactly. 6
yes.
months. Yeah, that is important because we are not supposed to prematurely withdraw the immunosuppression and so on. So that is another important part. Okay, that's it. Okay. So which is your agent of choice for maintenance of immunosuppression?
MMF will be the better choice as compared to Azuran for the maintenance, as there are so many studies in that shows the
Okay.
some studies are there is no difference. In some studies there is a MMF is better than Azuran, but there is a problem with cytopenias, like leukopenias in patient with Azuran, azathioprine.
Okay, so you have started this MMF and steroid and so on. What are the other supportive measures, supportive management?
In supportive management, we can start the patient on ACE/ARB inhibitors, like
Target blood pressure,
calcium
target
or
BP.
130 by 80, sir, as per the
Proteinuria is more than,
current
yeah.
EULAR.
Yeah, okay, fine.
The vitamin D, calcium supplement, we can start the patient for that rash sunscreen application, and along with starting this therapy, the vaccination, also we can give the inactivated vaccination to the patient, and
Yes. Yeah, vaccination, looking for hepatitis B, C, and retrovirus. Okay, influenza
yes, sir.
vaccine, pneumococcal vaccine, zoster vaccine. And they should, before giving very powerful immunosuppressions, they should rule out tuberculosis.
Yes, sir.
Okay. Rule out tuberculosis and elicit history of varicella infection during childhood or vaccination, prior vaccination. Okay. All those things are important. And ensuring appropriate nutrition and statins if there is the continued dyslipidemia beyond the target of that is proposed by KDIGO guidelines and so on. And once the GFR is declining or declined, the other supportive measures are important, like the mineralocorticoid antagonists and so on. And more importantly, when a young girl is there, you have to discuss, your counseling should not just stop short with achievement of remission and sustenance of remission. Definitely, you have to open up the discussion on when to get married and then when to become pregnant and what are the problems over there, because it's a huge problem. So there are a lot of social stigma, and many a times, once the patient goes in for remission, they conceal that and they get into marriage, and after marriage, because, they have not revealed the fact prior to marriage, the lady will not be able to reach hospital and get medicines and so on. It's a huge issue, and unplanned pregnancies and so on. So in a married person, you have to discuss, you have to counsel on various options for the contraception as well. Okay. Fine. So which contraception you will prefer, or which contraception you have to avoid?
Sir, estrogen containing we should like avoid in the SLE patient if we not sure about the APLA status of that patient.
Fine.
Or we can use the barrier contraception or progestin only contraception, sir.
Okay. And then of course UCD as well. And how do you manage the class 5 lupus nephritis?
The class 5 lupus nephritis on the basis of the amount of proteinuria, if it is less than 1 gram, 1 to 2 gram per day, we can start this patient on kidney protective measures and for the proteinuria, the ACARBs. If it is more than 1 gram of proteinuria, we have to initiate this patient on the steroid plus maintain immunosuppressions. Like in that, we can prefer the MMF.
Cyclophosphamide?
Yes, sir, can prefer the cyclophosphamide also.
Azathioprine?
But yes, sir, we can preferred
But that is not the
other like
choice, either
yes, sir.
cyclophosphamide or something or anything. So it has to be continued that way. Fine. Class 5. So we were discussing as to what are the lesions which are not described in the ISN RPS. What are they in the histopathology?
Sir, there are the lupus podocytopathy, they have not included and the tubular interstitial involvement, a collapsing lupus nephropathy, they have not
collapsing. Then most
yes,
importantly, thrombotic microangiopathy.
yes, sir, TMA, vascular involvement, another
So
part,
thrombotic
sir, vascular.
microangiopathy, collapsing
No,
glomerulopathy,
and
lupus
lupus
podocytopathy,
podocytopathy.
and acute interstitial nephritis. Okay. In addition to that, tubular functional defects. So these are all
Yes,
not described.
yes.
Okay. Fine. So in class 5 lupus nephritis, any particular antigen can be demonstrated. Now, membranous nephropathy, there are different novel.
Sir,
novel.
in that patient presented with class 5 plus that MGN part, exhausting 1 and 2
Exactly.
patient, yes, sir.
Right. Okay, so let's move on to the immunofluorescence. The immunofluorescence, how do you describe the immunofluorescence pattern in lupus nephritis?
It is full house pattern, sir.
What do you mean by full house?
In that we get all the positivity like IgG, IgA, IgM, kappa, lambda, and C1q, C3.
Right.
Everything
So
will come positive, sir.
The full house pattern in immunofluorescence in kidney biopsy is highly suggestive of lupus. Is it 100% specific for lupus?
No, sir. There are the other causes also for the non-lupus full house pattern. In that we have IRGN, in that HIV, COVID,
IRGN you
or
don't.
parvoid.
IRGN you don't get. No, IRGN you get
Not.
C3 dominance. C3 dominance.
Sir, that HIV, COVID, or parvo-related
No.
involvement.
In COVID and all, you don't get that at all. HIV, number 1. Number 2, hepatitis B virus associated immune complex. Fine.
Yes.
In HIV, what is that called? The entity which presents as proliferative glomerulonephritis with full house immunofluorescence pattern. What do you call that?
Hivik, sir.
Hivik is a broad classification. It's a broad classification that encompasses so many disease entities. This is called LLGN, lupus-like glomerulonephritis.
LLGN,
Lupus
yes.
like because it is the proliferative glomerulonephritis, exactly like the light microscopic appearance which you get in class 4, including your wire loop lesions. HIV is one condition where you can get wire loop lesions. After all, what is wire loop lesion? Because of the uniform prominent thickening of the capillary wall because of the subendothelial immune complex.
Deposition. Yes.
Yeah. See why all this happens in HIV. HIV, there are two broad different pathologies. One is the classical HIVAN, HIV-associated nephropathy, which is a collapsing glomerulopathy. The other one is immune complex mediated, which is HIVIC. HIVIC, you get LLGN, you can get even IRGN because of infections, you can have IgA nephropathy, you can have membranous, you can have mesangial proliferation, all that you can have. Okay, why all this happens? Can you get false positive ANA in lupus? No, sorry, in HIV, false positive ANA in HIV, anti-nuclear antibody. Yes, you can. Can you get a false? Can you get a false positive anti-DS DNA in HIV? Yes, you can, because there is a non-specific polyclonal cell activation.
Yes, sir.
In complexes, there also you can get that fingerprinting kind of appearance, or the reticular inclusions, all that you can have in both. Then how do you differentiate whether it is categorically it is LLGN, not class 4 lupus nephritis?
By considering the other
Because
lab parameters.
hypocomplementemia is not a
Yes,
feature.
sir.
No, hypocomplementemia is not there in LLGN. Okay.
Yes, sir.
So that's what. And again, as we said, the collapsing glomerulopathy is a very classical of HIVAN. The collapsing glomerulopathy can happen in severe lupus. Okay. So there's a lot of this sharing between this thing. Fine. You are talking about lupus podocytopathy. Can you just say a few things? When do you suspect a lupus podocytopathy? What do you mean? What is your understanding of that?
The patient presented clinically with a typical lupus picture with on urine routine he has a protein plus with the nephrotic range of proteinuria, and on biopsy
Yeah, the biopsy, light microscopy, what do you see?
it is like LM and IF will
Yeah,
be
it will
normal, and it is
like a minimal
EMA
change.
diffuse effacement of a food processes we will get, sir.
Yeah, so it is light microscopy. It just looks normal, like MCD. The only indication for biopsy there is a nephrotic proteinuria, the full-blown nephrotic syndrome. Okay. In the immunofluorescence, nothing will be there. So if you do an electron microscopy, you see a very diffuse food process effacement.
Effacement.
Okay. Understand? So so lupus is an immune complex disease, right? Immune complex mediated disease. Is it not? It is a classical prototype of immune complex mediated disease. You say it is a lupus podocytopathy, but there is no immune complex. Immunofluorescence is negative. So how is it happening? Here it is not immune complex. It is like your classical MCD, some permeability factor. Okay, some cytokine.
Yes, sir.
That causes the podocyte injury. This is number one. Number two, now the recent understanding of the lupus podocytopathy is that there are beautiful reviews on that. Please go through that. Few years ago published in JASN and so on. It is not always minimal change pattern. Usually it is minimal change pattern. You can have a very subtle mesangial hypercellularity as well in some patients. And more importantly, in some patients, you can get an FSGS pattern. So the importance here is that those patients of lupus podocytopathy who present with FSGS pattern, they don't do well as compared to those who are doing those who have an MCD-like picture. Okay, so these people tend to have more incidence of the tubular interstitial pathology, subsequently more incidence of acute kidney injury, and more incidence of relapses after some time and so on. All that happens with FSGS value. Okay, and again, in lupus podocytopathy, management is exactly like that of a minimal change disease. It's a very peculiar entity. Yeah, very peculiar entity. There are so many questions remain unanswered about lupus podocytopathy. Now let us move on to another pathology in lupus, that is TMA. I hope all of you know that algorithmic approach to TMA in a patient with lupus. So what are the, when there is a TMA, when you come across the TMA picture in the biopsy in a patient with lupus, how do you work up?
Sir, we can test for the ADAM-TS13 activity and antibodies to the ADAM-TS13, and we can
Very
test
good.
for the anti-phospholipid antibodies. After that, we can classify the risk stratification by using the plasmic score. And in that, if it is moderate to high risk, that is more than 5 points, we can start patient on plasma exchange and glucocorticoids till the test report will get. And in low risk patient, yeah, it is 0 to 4 points. We can further evaluate the patient after getting the test reports. In that test report, if we get the TS13 activity less than 10%, so we can label this patient as a SLA with thrombotic thrombocytopenic purpura, and we can start that patient on plasma exchange, glucocorticoids, and rituximab, or we can give plus minus caplacizumab in that patient. If it is normal ADAM-TS13 activity and negative for anti-phospholipid antibodies, we can evaluate that patient for the other etiology of a TMA, like complement-mediated TMA. If it is positive, came positive, we can consider that patient for the eculizumab, and we can evaluate the other etiology also and manage according to that. If it is another third possibility, like ADAM-TS13 normal, but it came positive for the anti-phospholipid antibodies. So we can label this patient for the anti-phospholipid syndrome nephropathy, and we can start that patient on anticoagulation plus minus plasma action if it is presented with a catastrophic APLA.
Exactly. Fine. So, but the thing is that practically the problem is that none of the test reports will come handy, right? It will take a lot of time. ADAM-TS13 and all that, very difficult. It takes time, and many centers don't have that facility. And again, genetic workup for atypical HOS also it takes some time. So on. It takes time. So most of the centers, they tend to preemptively start on plasmapheresis. Whether it is right or wrong is a big question. So these are the possibilities. It can be APLA, it can be atypical HOS, and it can be TTP. And then finally, it can be due to lupus per se. Okay, so that's it. It does not denote a particular etiology. Like TMA is a kind of a syndrome. Can be due to in the diverse settings it happens. SLE is one. So that's about it. And now let us move on to the currently popularizing drugs, the belimumab. What is belimumab, and can you name any trial which has employed
For the
belimumab?
belimumab bliss.
Yeah. I'm not able to hear you.
Stream inhibitor.
Bliss LN trial, right? Bliss, okay. And then voclosporin, what is that?
Voclosporin, it is a calcineurin inhibitor, sir. It is similar to the cyclosporin, but there is one methyl group of at a amino acid was different than cyclosporin, and it is better than the other CNI. Like it does not need the it is more potent, and it is easily attached to the cyclophyll complex, and it has a better pharmacokinetics profile, and it does not need the therapeutic drug monitoring, and less adverse effect also, sir.
Okay. So these trials, both Bliss LN trial and Aurora trial, they are very, highly expected questions in the either in Viva or in theory as well. But thing is that, there are a lot of reservations we have about this belimumab, clostridium, because both of these drugs are very, very expensive. And whether we do have the proportionate benefit, it's a big question mark, only the time has to answer. But please remember, there is a modification in the KDIGO guideline in classical lupus nephritis. The third option is that glucocorticoid plus either MMF or cyclophosphamide plus belimumab. That is one option. Of course, not the first option, the third option for lupus nephritis. So it means that, there are so many, the trials are ongoing and we have to wait and see before we embark upon. What is daratumumab?
It is a anti CD38, sir. It is also like currently one article suggests it is also helpful for decreasing the plasma cell, like long-lived plasma cell in our body
Exactly.
that
Then
are
anifrolumab.
Sir, anti-interferon 1 alpha inhibitor, sir. It is one of the main key molecule for the pathogenesis of a lupus nephritis.
Right. And also please go through the NEJ article on CAR T cell therapy for lupus, particularly refractory lupus.
Yes,
Okay.
sir.
Okay. Okay. Now, can you tell me something about the role of anti-C1q antibodies?
Sir, anti-C1q antibodies test is not available at
So there is a lot
lab,
of
but
importance given
yes,
about
sir.
2
But
decades
there is
ago.
it is
Yeah.
suggestive of a if it is positive, it will suggest the lupus nephritis
But it is
chances
not
are more.
specific. No, it is not specific.
Yes,
So
sir.
that is why that's fallen from grace. It used to be. Also, one more thing, it used to be popular in the yesteryears is the concept of nucleosome and anti-nucleosome antibodies. What is nucleosome? But again, it has just gone out of this thing, but still points of historical importance you should know. What is nucleosome?
CNS.
It is a portion of the chromatin, the portion
Yes,
of the
sir.
chromatin.
Yes.
But I've heard about the apoptosis, the endonuclease cuts internucleosomal cutting, right? The histone, the core around which the chromatin is wound upon, and then a free chromatin, like that.
Yes.
The nucleosome is one histone bound with the wound chromatin, and then a free chromatin. So this is nucleosome. There are a lot of concepts about it, and there again used to be popular thinking in early 90s, that actually there is the genetic basis dysregulation of apoptosis and delayed clearance of apoptotic bodies is the
Yes.
root cause for SLE and all that. So now it is all, we don't think about it. Much more than apoptosis, there's netosis. Uncleared apoptotic bodies are less immunogenic than the components of the netosis. That's why I started this today's session with the netosis. So that also is
Yes.
gone. So there are
Yes.
many things which are just set aside: LSL phenomenon, nucleosome, and role of apoptosis, and then anti-C1q antibodies. All these are anyhow, but you need to know all these things. What are the animal models for lupus?
Mice. Yeah, I'm not aware about that, sir.
Yeah, animal models, meaning there are some animals which have a propensity to go in for spontaneous autoimmunity, and particularly SLE-like phenomena, particularly New Zealand black mice. NZB. That's number one. Number two, the F1. That is the first generation hybrid of a New Zealand white cross New Zealand black. Okay. There are other animal models as well. Again, the animal models is things of the past. But I always love learning about animal model because that is how science evolved. But now you have all these omic analysis, the transcriptome and the high-end genetics and molecular biology. So the animal models based learning has just gone, but still it doesn't mean that we should not, for every disease, learn about animal model. It wouldn't take much time because, it's at least it's a way of respecting the researchers and scientists who pave way in understanding of all these diseases. That's what. Okay. And now coming to the management of this particular unfortunate lady, how do you manage her now? The final part of the discussion. Now she's with the diffuse alveolar hemorrhage, very low hemoglobin, creatinine 10. How do you manage? That's what you presented, right?
Yes, sir. Yes, sir. Sir, the patient presented with anemia, severe anemia, and she had a decreased urine output with creat of obtained with urea of 220, around 220. So we have initiated her on dialysis with, we have given the PRBC transfusion, and we have ruled out the first infection in this case, and we have done the imaging. It was clearly suggestive of a DAH, and followed by the suspecting the she was lost to follow-up in past, so we don't know the exactly it was like refractory lupus nephritis or just she also had not received endoxin in past, likely because of the she might had a conceive, or like she needs a conceivedness in the past. Currently, we have treated him as a lupus nephritis flare with the DAH. We have given the MPS pulse. We have started on MPS pulse 500 milligram for 3 days, and we are planning to give a endoxon by NIH protocol. It is a 0.5 to 1 gram per
Why do
meter
you
square.
prefer NIH protocol for
High
that?
dose, she currently presented with a life-threatening disease and the flare, and we have also started her on plasma exchange for till the recovery of a DH, or the build hemoglobin will get built up till that
Fine.
period.
And you have to look at the kidney size, and you don't know how much of chronicity element is there.
Yes, sir. Yes, sir. Yeah. After stabilization, we are planning to do the kidney biopsy.
Biopsy only if the kidneys are still normal size, because
Not
you know
normal
there is a lot
size.
of,
Yes, sir.
yeah. Now it is a saga of 18 years from 2006 to 2024, and so many flares and so many discontinuation of medication, non-adherence, and so that is a big question. The flares predominantly, we don't know what is the serial creatinine just before this presentation, right?
Yes, sir.
For some time she was not there with you.
She was lost to follow-up, sir, around
Yeah.
2, 3
So,
years. 3 years, sir.
so
She lost
3
to
years,
follow-up.
meaning so the creatinine might have been progressing over 3 years. It is not just 1 milligram now presenting with 10 milligram. We don't know the creatinine over the 3 years. Now the current flare might have predominantly affected the lungs. We are not sure about it, right? You know, but so here comes the importance of taking a complete picture. You should do urine routine and look for the presence of RBCs and CAST, and then complement levels and dsDNA, and then other phenomena of thrombocytopenia and leukopenia and so on, all those things. Okay. So when do you, while counseling a lady with lupus for pregnancy, how do you counsel? When one can become pregnant based on the current guidelines?
Sir, at least she had she has to like 6 months of a complete remission minimum, and we have to shift the if she's on MMF maintenance dose, we have to shift him on Azoran at least 3 months of before the conceiving
At least 6
time.
months of the sustained physics of the disease, at least for 6 months. That's mandatory. And never forget to start aspirin prophylaxis after 16 weeks itself, number one. And then please continue HCQS. And then the steroid can be continued, and CNI can be continued. Okay, HCQS has to be mandatorily given. And the problems are the increased chances for preeclampsia, right? The
Yes, sir.
SLE flare that can happen. SLE flare, particularly the peripartum period, it can happen.
Very important. Yes.
Yeah. Currently, in initially many centers, prophylactically they used to hike up the dose of maintenance dose in the third trimester and so on, but there's no solid background and solid evidence for this. So there is a lot of variations. At least some authors believe that there's no need for preemptively increase the dose of the maintenance immunosuppression in the third trimester and peripartum period. And then the question of breastfeeding of the baby, and which are high chances for UGR and prematurity. So that has to
Yes,
be
sir.
discussed. And the rare chances for transfer of one particular antibody transplacentally causing something in the infant.
Congenital heart
Heart block. Heart block.
heart block, sir.
The low and raw antibodies.
Row and RAW, sir.
Low and raw antibodies. There is much more to be discussed, and I think time is up. So again, I go back to the 10 common mistakes the nephrologists commit doing this, right?
Yes,
and
sir.
particularly, there is one particular very important thing which we did not touch upon is the indication for the second biopsy, repeat biopsy.
Yes, sir.
When do you do
But
that?
sir, it is like we can we have like two protocol, like if we need to stop the immunosuppressions patient in a quiescent thread, that per protocolized biopsy. In that, we can do the biopsy and see the activity and chronicity index, and then we can take the decision to stop immunosuppressions or we have to continue that. And like this patient presented with the lupus nephritic flare, so we can do the renal biopsy, and it will give the idea regarding to modify the regimen or to take the decision for the treatment part, sir. And
Yeah.
there is
And
a
when you are not,
there is
when you are not able to differentiate between a class switch or some other cause for the worsening of the kidney condition. Okay. So to prove
Yes.
that it is a class switch, if it is a class switch, you have to be more aggressive, or if it is a non-lupus causes that is causing a fresh appearance of proteinuria, worsening of proteinuria, and worsening of the kidney function and so on. So a lot of tricky issues on a repeat biopsy. That please go through that again.
Yes, sir.
That's important. And there are certain practical points. In a number of instances, you'll come across a patient doing pretty well. Hematological parameters are fine, no clinical evidence of activity, and complement normal, dsDNA negative. But still, there can be 0.6 gram proteinuria or 0.7 gram proteinuria. In this situation, it doesn't mean that you have to be very aggressive in immunosuppression.
Yes, sir.
Because there can be discordance between the
Clinical and histological discordance there.
Yeah, there can be, because this we learned from another disease, that is the primary membranous nephropathy, where the immunological remission happens to start with, and then clinical remission, whereas proteinuria persists for 18 to 24 months and so on. So it takes time. It doesn't mean, so you have to be a little patiently observing the patient when everything is else is under control. You do not keep on doing repeat biopsy. You will not escalate the dose and so on. That's important. Just the vice versa is little more troublesome, meaning urine sediment normal, no proteinuria, clinically no evidence, nothing of this thing. Whereas there are any number of instances, a biopsy reveals active inflammation. So this is the reason why the current KDIGO guideline says that your total duration of therapy has to be at least 34, 36 months.
Yes.
Many times there can be a discordance between the active inflammation in the kidney biopsy in a patient in whom there is no significant proteinuria. So this also is there. And again, please remember, proteinuria can be in the later stages. It can be due to, all proteinuria doesn't mean activity. It can be due to evolving glomerulosclerosis. That itself can cause proteinuria.
Yes, sir.
Yeah, in that situation, we are not supposed to hike up the immunosuppression. Okay, in those tricky situations, you can subject the patient for kidney biopsy. Okay, so the common mistakes which we do, number one is improper dosing of steroids. This is another important, the recent development. Now, the nephrology, the clinical nephrology is more towards reducing the dose of steroids. Okay, gone are those days 1 gram 3 consecutive days, and all patients to start with 1 milligram per kg and all that. No. So mild, moderate, and severe reduction dose, and 0.5 milligram, 0.6 milligram per kg itself is enough in most of the patients to start with. And by 24 weeks, it has to be less than 5 milligram when the remission is achieved. So that is an important paradigm shift, is reduction in the dose of steroids, not only in lupus. And ANCA disease, actually, the importance of steroid is almost deadly. So improper dosing of steroids. So where it has to be escalated, it has to be escalated. Where it has to be down. So number one. Number two, the concept of the non-adherence, which is very widely prevalent in our society. So any worsening of the clinical situation, we think it is the unresponsiveness. So always you have to devise a mechanism of picking up non-adherence. And again, third point, the cyclophosphamide thinking that it is a gold standard. It is not so. Okay, even in class 4 lupus nephritis, in situations where it should not be given, please don't give. You can always give MMF. Okay, and forgetting to ensure that the patient is taking hydroxychloroquine and with appropriate and the periodic evaluation of the eye. And another common mistake we may do is that relying only on urine sediment for assessing the response. Okay, as I've already said, even though urine sediment is very important, don't keep that alone as a kind of a benchmark for making decisions, because you can have RBCs due to simple cystitis itself. Okay, and not scaling the immunosuppressive intensity based on the class. So some people will be initially started on something, and without understanding that there has been a class switch and that there is a potential for class switch, without understanding that, just accepting the gradual worsening of the kidney function mutely without doing anything. So that is another mistake. And forgetting about the prophylaxis, particularly in the high dose of steroids, you have to give PCP prophylaxis and the vaccinations. Okay.
Yes.
And another thing is that failure to down scale the immunosuppressive dose in advanced kidney pathology. We pretty well know that the CKD has set in, but still, we'll not have, in some patients, appropriate reduction, gradual reduction of the immunosuppression, because at that point of time, it is not going to be of any use. And very often forgetting to counsel and discuss about the pregnancy issue. So that is a very important thing. It is very absolutely important. Your management becomes incomplete if you don't address and discuss about it. And another 10th mistake is that sometimes, over enthusiastically venturing to do kidney biopsy. In that particular patient, biopsy may be a little risky because GFR pretty low and borderline thrombocytopenia platelet count, and the biopsy report is not going to change your therapeutic strategy. In that situation, don't unnecessarily do biopsy. So this is the 10 the common mistakes as clinical nephrologists we do. And this article came up many years ago, but still it is holding on. And again, as you rightly said, it is not only immunosuppressive management. Equally important is that non-immunosuppressive management as a whole. More importantly, this is the disease of women. So that has a lot of social issues and the family issues and so on and so on. Every major center should have exclusive lupus clinic because, that should involve a clinical psychologist for counseling, and the family members have to be counseled because it is a very peculiar disease, particularly women of the lower middle and lower middle class and the lower state of the society, they suffer a lot because of that. Why is it disease of women? Last question.
Sir, in that there is no they have given some
Single most
tricks.
influence is estrogen. Single most influence is estrogen. Most important is estrogen. Okay, that's why in the pre-pubertal girls the incidence is very low, and postmenopausal incidence is very, very low, and increased incidence of SLE in the Klinefelter men, where XX. Okay.
Yes.
Yeah, that's it. Okay. I think we covered about a minuscule overview of lupus. Lupus is such a grand disease with protein manifestations, a great masquerader of so many diseases, and it's very difficult to just discuss the whole lot of it in 1 hour. We just touched upon, and let this be a stimulus for learning more and more. And I congratulate you on most of the questions you answered well. And I know it's very difficult to present in front of a huge audience like this, but you did well. Thank you so much. All the best and good luck to you.
Thank you, sir. Thank you, sir.
Thank you, sir, for such a elaborate discussion, and good job, Yogesh. So there are a few questions in the chat box that we will like to take. Like, what's your take regarding weaning of immunosuppression? Like after 3 years of immunosuppression, do you do a kidney biopsy before you stop immunosuppression, or do you taper and stop?
Uh, uh, yeah, it all depends on what kind of patient you deal with. Most of the patients, I would not stop abruptly. Even after 3 years, I try to maintain at least on 2.5 milligram prednisolone, because only time only has to answer whether this practice is right or wrong. As I've already said, once you withdraw immunosuppression, again, there's a huge responsibility that you have to be closely monitoring for any relapse. And I think a patient who had a very florid presentation to start with, very high activity index, I would be hesitating to totally wean off. At least I'll maintain on 2.5 milligram of prednisolone if there is no issues related to the drug.
Okay. So second question is, before transplant in lupus patients, do we need to take any precautions?
Yes, exactly. Like transplant and lupus, actually, there are some issues. One is that you should be very clear that the disease is not active. Sometimes the clinically present, only hypocomplementemia alone will be there in some. Okay, and in some, just a vague presence of ANA alone. But now people are very categorical. Such isolated anomaly does not mean it is active. You have to take a collective this thing only, number one. Number two, here is this is the disease where there's a theoretical possibility of a false positive cross match because of the autoreactive antibodies, because of IgM antibodies, and you have to do auto cross match, and that can be easily this thing. So the point of interest, second point. Third point is that you should not forget to rule out a secondary APLA. Okay, if there is a secondary APLA, the chances for graft thrombosis is there. Necessarily, that should have been ruled out. And the fourth point is that the classical Rubin's calendar of the profile of post-transplant infections, like, the first month only certain infections, and the infections like viral infections like CMV, BK virus, PCP, all that happens only after first month. That may not apply for a lupus patient who has been on immunosuppression for 2 decades, 1.5 decades, 2 decades, and so on. So you can get the infections which we normally get only after first month first month, you can get in the first month itself sometimes, We have come across CMV and all that, because, already the low immunosuppression is there. The final point is that the patient will ask you, or you have to say that what is the chances for recurrence of lupus nephritis post-transplant. You have to say that the recurrence is not that high, but still it is happening. And most of them, it does not lead on to a severe graft failure. Again, it is a point to ponder over, because, post-transplant, you are on triple immunosuppression. Almost all effector mechanisms you are handling, but still how the recurrence happens in some is a big question mark.
So next question is, like if a patient is contemplating a pregnancy, so at what time we will change the MMF to azathioprine?
Yeah, to be on the safer side, at least 3 months. At least 3 months prior to the planning, because MMF is potentially very highly embryotoxic, and it has to be done. And again, there are instances where after switching over from MMF to azathioprine, SLE flares have happened in our institution. That will be closely monitoring the patient as well. It's not just that switching over and without supervising it, the patient should not just let out. Yeah.
So next is, can complements be normal in active lupus? Like hypocomplementemia is not universal; they can be normal also. Like
Exactly. Rarely we come across normocomplementemia. So it is not the sole parameter to decide on the clinical activity. The complement levels in the immune complex diseases, it is very, very interesting. There are certain immune complex diseases where there is no hypocomplementemia. For instance, even IgA nephropathy, now we know it is immune complex disease. Galactose deficient IgA and anti-JD-IgA. But why there is no hypocomplementemia? Of course, there are explanations. I'm just saying that, So, but here this is a disease where there is floridly hypocomplexemia is very strongly associated with the disease activity, but aberrations do happen.
When do we decide to give high dose cyclophosphamide, like the NIH protocol? What are the conditions where we will give NIH protocol?
Actually, NIH protocol has fallen from grace. Your urolupus definitely works even in the worst scenario. But now the current concept is that instead of approaching lupus management, lupus nephritis management as an artificial dichotomous idea that, first you induce remission and then the sustained remission and so on. Now, the current concept is that, I don't know which journal recently in May 2024, if I remember it, KIA, a beautiful articles, the way forward in lupus nephritis, the current concepts. Like this kind of a division is very arbitrary and very artificial. This dichotomous splitting of induction of immunosuppression, induction of remission and then maintenance of remission. What they say is that if the pathology is very florid, right from the beginning, strike very hard, and keeping in mind preservation of the kidney function. That's it. There are some researchers who say that you can add the third drug, the tacrolimus there itself, instead of escalating the cyclophosphamide dose, particularly in a country like India, where the infectious complications of immunosuppression is pretty high. So there may be very few instances where we have to resort to high dose. The urolupus, we are very convinced urolupus regimen works very well. If at all, you can add the third drug, like tacrolimus, to start with itself.
On a lighter note, someone has asked, like, who should treat lupus nephritis, a nephrologist or a rheumatologist?
Always, every major institution, there'll be a tussle and tiff between the two. But very humbly, I would say, nephrology is one subspecialty which is very close to the grand major specialty of internal medicine. Because, most of our teaching rounds end up discussing only the medicine issues. At the end of the long teaching round, I would have realized most of the times we haven't discussed anything nephrology specifically, but actually, we head to foot, we discussed a whole lot of it. Even today, I was just wondering, the precious time was wasted in discussing vanishing lung syndrome and so on, because I couldn't resist that, like we always look upon patient as in its entirety, with due respect to all other subspecialists. Nephrology is a subspecialty. We are in a better position to understand what's happening to our patients, and I feel that we should be treating.
Thank you, sir. Due to the paucity of time, we'll be closing our session. Thank you, sir. Thank you, Yogesh, Dr. Vineet, and everyone for attending our bedside.
Thank you
It
so
was
much.
a very nice interactive session. Thank you.
Thank you, sir.
Thank you so much.
Thank you. And good night.
Thank you, Vineet. I'm leaving.
Thank you, sir. Thank you, sir. Good night, sir.
Good night.